here we go again at the Arthritis Broadcast Network. I'm at CR Arthritis, and I'm here today. Oh, I'm Kelly English from the Arthritis Society, or Arthritis Research Center. I'm on the Arthritis Patient Advisory Board, and I'm here today with Matthew Jessome. And Matthew Jessome was one of the poster presenters yesterday, and I thought your poster was really, really clear. So I'd just like to start with how you got it, whereabouts you are in your education right now, and where you see yourself going.
Yeah, absolutely. So thanks for having me, Kelly. So I'm a second-year medicine resident, so that means I'm done my medical school training and I'm doing an internal medicine residency, as it's called. So that's before you do training as a rheumatologist. I do some work in research with something called vasculitis. In particular, it's a large vessel vasculitis called giant cell arteritis. Some people might also know this as temporal arteritis, and it's one of the most common causes of vasculitis that's out there. I can provide a bit of background on what exactly that is, because oftentimes when folks go to a rheumatologist, they think about joint pains. And vasculitis, although it's in the realm of rheumatology because it's an inflammatory issue, often like rheumatoid arthritis is thought to be, we don't really think about it often as much as falling under that same umbrella. So what it is something that, giant cell arteritis is something that you have inflammation or swelling of blood vessels, usually big ones. And the most common concern with giant cell arteritis is when the swelling causes problems, specifically vision loss.
It's vision, isn't it?
Vision loss is the most, I wouldn't say necessarily the most common way people will have it, but they'll complain of a headache very commonly. The biggest concern is vision loss and sometimes other problems with big blood vessels when they get inflamed. Usually this affects folks over the age of 50, often actually in their 70s.
The people I've heard have been over 50, as a matter of fact. They were 70s,
yes.
Late 60s, 70s. So.
Exactly.
Yeah.
And the challenge with giant cell arteritis is actually that it's still difficult to diagnose and also to know who needs treatment right away.
Exactly.
And so our research was trying to look at, could we develop a clinical prediction score for knowing who needs to be started on steroids right up front, because that's the treatment for it, to prevent problems like vision loss. And also, who should we send for further testing? Often a rheumatologist will offer testing like a biopsy of the temporal artery, or sometimes imaging like ultrasound or MRI. Unfortunately, even these tests are not what we call a gold standard, because sometimes a biopsy or an image will actually be unable to pick up the lesion that we're looking for in giant cell arteritis. So we're looking for a tool that would be helpful for doctors, like rheumatologists, right up front to help us tell us, do we need to start this person on steroids, and do we need to send them for further testing, which remains a challenge.
Right. And the steroid treatment is a large steroid treatment, is it not?
It's high doses of steroids, oftentimes about 40 to 60 milligrams of steroids. So this is something that you can't have long term, but short term you start at a high dose, and if it is giant cell arteritis, you wean down. You go down to a slow taper down up to hopefully something below 10 milligrams, but you have to just follow patients very carefully because you don't want it to flare up again. So it's something that has to be taken quite seriously.
I'm smiling not because I'm not taking it seriously, but I can't imagine being on 40 to 50 milligrams of prednisone for very long.
No rheumatologist is happy with that.
Cleaning the house. Oh, it's just awful,
Yes.
awful. And how long does this treatment quite often last?
Yeah, oftentimes, so rheumatologists will have to very closely follow a patient once they're on steroids and wean them down usually weeks, if not months typically, if it really is giant cell arteritis. And hopefully we can get them to below 10 milligrams, and hopefully there won't be any sort of flare. And in some cases, you might even think that people can be on very low doses, or in some cases get off of steroids, but it always has to be a patient-by-patient case basis, depending on what you think.
So that's really difficult too. Then it's not like you're going to be on steroids for 2 months standard or 1 month standard. It would have to be individualized with a lot of care then.
Yes.
Okay. And does this often, is it associated with another arthritis as well? Or is this usually a mono type?
Right, it's a very good question. So giant cell arteritis in and of itself typically does not cause arthritis. When I say arthritis, I mean inflammation of the joints. It is associated with a condition that some folks might have heard of called polymyalgia rheumatica, or PMR for short. They're thought to be cousin diseases in a sense, and this can present with joint pains, but largely the actual disease process isn't, so to speak, a joint problem, but it's more the areas around the joint we sometimes use the word periarticular, but that's just a fancy way of saying it's not the joint itself. But it's a cousin
around.
disease, and oftentimes can present with giant cell arteritis.
And it's extremely painful from the people that I know.
Yes.
And it does hit older, am I correct?
Yeah, because it's a cousin disease of GCA, it's very much the same demographic that'll be affected oftentimes, and the treatment is also therefore very comparable.
And I know that people that I've been talking to, they've had to go on steroids.
Exactly.
And it's quite traumatic actually to go on steroids. You go on a large dose and it really does affect your whole being. So what kind of things would you use what kind of tools are you trying to develop?
So what we had is, with some expert opinion, we derived a clinical prediction score. It's called the Bafsar-Khalidi score, much easier, just be BK for short, and that's a score that uses things like symptoms. So headache you might be having, pain in the scalp here, something called claudication of the jaw is another typical feature of giant cell arteritis, where it's basically where there's not enough blood flow to the muscles of the cheeks there, and because of that, when you're chewing, you might get some pain, called claudication. Then it also looks at things on exam findings, so for example, if there's tenderness when a rheumatologist will push, as well as some blood work, like inflammatory markers like CRP and ESR. And taking that together, we can make a score that's easy, it's just numbers, so it's 0, 1, 2, 3, etc. And we can try and stratify folks who are either very low, medium, or high risk for GCA. That'll help a doctor decide, is this something we need to send for further tests and start steroids, or not? And initial work on this has shown that what we call the sensitivity of the test, which tells us how many people who really have the disease are we able to pick up, it says that it's been pretty good. And so my work was looking not just at that, but building off of it and seeing if the reliability between raters was something that's also reproducible.
Well, if I had giant cell arthritis or some of these symptoms, I would be really pleased to see this, because I imagine it wouldn't take quite as much time in a rheumatologist's time to properly diagnose. But also it means that I might not get put on high doses of steroids if I needed just medium. Is that correct? Is that sort of how you see it being used?
It's tricky. It's the way that rheumatologists have to approach it is somewhat of a yes and no approach.
Okay.
We can't kind of go halfway with it. It's more of a, if we're going to go with the steroids, you've got to go
okay.
with it.
Okay.
Because that's the dose that we think is probably effective and safe for preventing the main complications,
right.
like vision loss, which is
it's
bad.
serious. That's right. I'm a reader.
So it's tricky for that reason. So it's something that at the current time, really the gold standard is, at this time, it's the clinician's final opinion about whether or not this is something that's high risk. But it's nice to have a clinical tool that can help validate and verify what the doctor's thinking about. So it just provides an additional layer of reassurance, especially if we can get a tool that's very well performing and easily accessible to folks in different clinical settings. So our work was largely just validating this initially in a rheumatology setting, but I can imagine family doctors and emergency room doctors all seeing this as a potentially useful tool, because they're folks who will be seeing primary care issues of all varieties, including people who would come in, they're 70 years old, they can have this headache that's going on, it's a very bad headache, and they might have some symptoms that make them worried about giant cell arteritis. It'd be very useful for them to have a tool to know if they should be starting steroids and referring out to a rheumatologist right away.
Exactly. Thank you so much, Matthew.
Mm-hmm.
This has been really interesting. And I know that this is a population that sometimes gets not ignored by no means, but they have a little bit more trouble getting some lay summary information.
Yes, it's not the most common condition. About 1 in 10,000 people will have this, but it's something that is definitely important for people to be educated on, and I'm happy to shed a little bit of light on the background here. Yeah.
Well, I wish you the best for your future studies. Nita, have we got any burning questions out there?
What is the most surprising finding from your research?
The most surprising thing that is probably what folks will find most surprising is that the tools that are there for giant cell arteritis are just unfortunately not the same where we can say, here's your test result. And I think this is pretty common in rheumatology, just all around the board, but we still haven't got the answer to how to diagnose it the best, because even the biopsy is only going to catch the diagnosis 90% of the time. That leaves 10% of people still
right.
Still
floundering.
What do we do? And oftentimes people will have what we call biopsy negative giant cell arteritis. And so I think people will find that surprising, that we still, without a biopsy, will actually still be treating people with steroids for giant cell arteritis, because unfortunately that's actually probably the safest way if we really still suspect it, because we don't want vision loss and all the other complications.
No, and much as I hate steroids
Yeah.
at very high doses, I hate to lose my vision even more.
It's always a risk-benefit discussion with the patient, of course, right? Yeah.
Thank you very much.
You're very welcome.